So I'm here to talk a little bit about sort of some of the attempts that have been made over the years to improve the quality of pain management in kids, and in particular focusing on Childkind and its history, to give you a little background on where we are now. So the 80s were a good time for some people, it appears, who had a good time in that period. There were some issues around clothing that perhaps were less than ideal, and around hairstyles also, which perhaps were less than ideal, but it was a particularly challenging time for children in hospitals at that particular time, infants, young children, for whom pain was an issue which was really not very well recognized. And for many of us who were around in that era, we can recall all of the kinds of things that happened to babies and children in the hospital without really a second thought, honestly, because pain just was not an issue. So 30 years ago, pain in the newborn was essentially a non-issue. As you know, the word infant comes from infans, which means voiceless, and children truly were voiceless in the newborn period. We did some surveys in the mid-'80s or so looking at what people thought, when people thought children felt pain, and about 20% of clinicians thought that babies didn't even feel pain, let alone do anything about it. At that period, intraoperative anesthesia was often not used. Postoperative anesthesia, especially for newborns, was essentially non-existent. And the pain of procedures, which were very common in the NICU, as most of you are familiar. In some of the studies, 120 or 30 perturbations a day in the NICU were essentially completely unaddressed and not really even considered. Let alone the pain of children in hospitals. And in 1968, there was a sort of a paper in the medical clinics of North America by an intensivist who said basically children don't feel pain and we don't need to treat it. And then Joanne Eland, who recently died, for those of you who know of her or whatever, was a wonderful person, did sort of some very preliminary work and in a master's thesis in nursing that she did at the University of Iowa hospitals, and found that essentially children received no postoperative pain management. She looked at 25 kids, and 12 of them didn't even, 13 of them didn't get anything, 12 of them got something, a total of 25 doses over the course of their entire hospital stay. In the mid-'80s or so, people started to look at the disparity between pediatric and adult management, and there was an enormous disparity. And even adults were probably pretty undertreated at that time, but there was a massive disparity between adult and pediatric treatment. It goes without saying that cancer pain was not really well addressed, certainly end-of-life care wasn't, but even the pain of procedures, and which are a major source of distress for most children, but particularly those with chronic disease. In that period, procedures often required physical restraint, bone marrow aspirations, bone marrow biopsies were done with only local anesthetic for the most part, laceration repairs in the ED. Kids were tied down. Analgesia and anesthesia, when used for procedures, was typically a mixed bag of things. So one of the typically was, again, it's going to sound hard to believe to most of you who grew up in a different era, but what we would use typically would be chloral hydrate, or this bizarre concoction called the DPT, which was an injectable combination of medications that was developed in France for suspended animation. But that was the typical sort of treatment for most procedures in children. This was sort of what sedation was like for the most part in that early era. So 30 years ago, postoperative pain was really not very well addressed. It was an afterthought. Disease-related pain was often very inadequate, even kids with cancer and other chronic diseases. Newborn pain and procedure pain was essentially ignored. And why is that so? Why did that happen? I mean, everybody in this room is nice. We were nice then. Why did this sort of happen in the way it did? Well, there were complexities around assessment. There were ethical constraints on doing placebo-controlled studies in children. And the whole issue of assent and consent was problematic. There were no financial incentives for the most part because the pharmaceutical industry had no interest in this smaller market. Textbooks weren't available with any sort of information. There was a letter to the New England Journal by this person in 1987 or something, looked at 12 or 10 pediatric textbooks, which consisted of about 12,000 pages, and there was one page on pain in the entire composite of those textbooks. And that allowed the persistence of all of these kind of myths about children don't feel pain, analgesics are too strong for them, they don't really need it, they don't remember it. So what happened? Well, gradually, there were a couple of sort of seminal events, sort of earthquakes in the history of this field. And the main one was somebody named Sunny Anand, who some of you may or may not know, who published a paper for, I guess, it was part of his fellowship at Oxford, where he looked at kids or newborn babies who underwent anesthesia, underwent ductal ligations with anesthesia. Was pretty primitive in that era, and then those who did not, because it was not infrequent that children would undergo a ductal ligation without any anesthetic. They just received curare, and that was it. There was no altered sensorium. And he found this massive outpouring of stress-related hormones and a very, very different outcome of the kids who received anesthesia from those who didn't. And suddenly that created this recrimination amongst everybody doing this kind of work, and suddenly people said, oh my God, we can't do this way anymore. And in addition, there was a whole lot of work. Mariah Fitzgerald and the group from London started looking at newborn, primarily rodents of one sort or another, but also did some work on newborns as well, newborn humans, and found sort of that there was increased perception of pain after multiple procedures. Anna Taddeo did similar work with circumcisions. There was increased recognition of the disparity between the way children and adults were handled. And suddenly, this created this outpouring in journals, and within about a year, there were 7 editorials in the major medical journals, New England Journal, British Medical Journal, Lancet, one after another, suggesting it was barbaric to do what we were presently doing, and demanded a sort of change. That demand ended up looking like this, because as you can see, this is just an engram from Google, but what you see is, starting at about the mid-'80s, this dramatic outpouring of information and research on pediatric pain that occurred, starting at that period, and has really continued to the present time. So 30 years of pediatric pain, even more now, almost 40 years of pediatric pain research has really had a significant impact. We have a better understanding of developmental neurobiology of pain. We have all kinds of increased information on the safety and efficacy, pharmacogenomics and pharmacokinetics of these agents in children. We understand much better the multifactorial nature of pain. We've developed all kinds of successful behavioral strategies, and we now basically have the ability to assess and treat the overwhelming majority of pain problems in children, regardless of their age, regardless of their cognitive ability. Many of the people in this room have been responsible for some of those important changes. Yet, when we look at some of the recent studies, and not all recent, but certainly mostly in the recent past, there still continues to be a large number of children who seem to be inadequately treated. Kozlowski, in a US study, 40% of post-op children had pain that seemed to be essentially needless. Similar studies in Sweden. Bonnie Stevens and her group did similar work in Canada. Ricardo Carbajal did work on pain relief in infants in multiple NICUs in Paris, and demonstrated lots and lots of procedures that were inadequately treated. And there was enormous intra-institutional variation as well. Alan Finley looked at some places that were not in the sort of Western medicine canon, and in Thailand, for example, and found enormous undertreatment of kids, much more significant than even in the Western countries. Joanne Wolf, in a New England Journal article, in children with end-of-life care, found that many of them, most of them, had pain that probably could be more adequately treated. And that's despite the fact that we now have the ability, the increased interest in pain, and increased research in pain management. We recognize that there are long-term negative consequences on inadequately treated pain. And despite the fact that parents want it to be differently. This is a study I often quote by Amendorp from the Netherlands, who looked at 300 or 400 families of kids who had persistent pain and asked them, what is your priority for this hospitalization, and what is your satisfaction with how adequately that priority has been treated? And of all the categories they identified, pain had the greatest gap between it as a priority, which was second down the list after curing my child, comfort, and the greatest gap between their satisfaction with the success of treatment of that priority. So there remains very significant intra and intra-institutional variability. Many children continue to have unnecessary pain. There's limited data on the world at large, other than some of the kind of Western countries for the most part, but by extrapolation from some of the work, there's very significant pain problems that are very common in other places as well. So, with that as a sort of background, what seems to make a difference with this? Well, as early as 1990, John Bonica, who many of you know is sort of the father, I guess grandfather of pain medicine, who started thinking about pain as an entity itself worthy of investigation and treatment, suggested that even in the adult world, what seemed to make the difference was the lack of application uniformly of what we already know. And in fact, we knew more than enough. Certainly there's a lot of research that was coming out and continued to come out, but the problem was largely the uniform application of what we presently know. So there have been lots of strategies that have evolved. All of you are familiar with sort of changing practice and getting people to change what they do routinely. The educational strategies have been out there for a long while, guidelines and quality improvement. I'm not going to go into the details of those literatures, but unfortunately, looking at each of those strategies independently, looking at, for example, the Cochrane Library reports on those meta-analyses of most of those entities, in and of themselves, each of them independently, don't seem to account for a lot of the variability and don't account for sustained change. I think Gary's going to talk about guidelines in particular tomorrow, I think. But regardless, guidelines have been developed by many of us, not uniformly used. Educational initiatives not uniformly able to demonstrate sustained change. Quality improvement, which one would think would be a cornerstone of this, in and of itself doesn't result in sustained change. And even combinations of them, there were a couple of them, a number of initiatives. There was a German initiative by Zernickow. There were initiatives from the American Alliance of Cancer Pain initiatives, looking at multiple institutions trying quality improvement and education, and despite all of that, they still identified a number of people who still were inadequately treated. So what does make a difference? Well, it seems like there was sort of, through all of this time, there was this seeping of suggestion that the culture had to be changed within the institution, that it was it had to be an administrative imperative, that the culture of the institution had to find that persistent pain was, if you will, ego-dystonic. It didn't fit into how we handled people, and that kids who were still uncomfortable were outliers, and that wasn't the way we wanted to proceed. So there was a lot of work by a number of people, most of the nurses, looking at the culture of units within institutions and finding that by changing the culture, if you will, within an institution and comparing the units to other units that hadn't had a similar intensive expectation of change, that things were better when we did that. So in other words, what was suggested was that pain relief had to be institutionalized, that it couldn't be a couple of nice people who were committed to this, one orthopedic surgeon, one hematologist in the group, and then others not doing a similar job, that there had to be some uniformity, that individual initiatives were not really sustainable over time, and that we had to have pain management as a core institutional value, similar to, for example, the way safety and confidentiality are core values of institutions these days. And as I implied to you, that pain management, inadequately treated pain, was out of context and would stand out within the institution. And people who were purveyors of that type of care would be identified and able to be influenced, if you will, if the institution and the administration was in favor of that. So how does that happen? Well, that was sort of the background to this. How did we do it? So a number of people who have been instrumental in this field started thinking about how do we create institutional change. The sort of seminal article in 1990 was by someone named Mitchell Max. I don't know if anybody knows. Dan and Christina know Mitchell Max, who was a wonderful man who did a lot of work, neurologist, did a lot of work on neuropathic pain. And he published this paper in the Annals of Internal Medicine saying, is education enough? How do we change analgesic practice? And he said basically not. And he suggested the type of things that I'm suggesting to you now. Betty Farrell, who is a nurse at the City of Hope, started this whole notion of institutionalizing pain management. And she did that primarily at a cancer pain hospital at the City of Hope out there. But there were a number of other folks started to jump on the bandwagon. June Dahl from University of Wisconsin, who was the angel responsible for getting JACO to sort of think about pain management, if you will. That has its ups and its pros and cons. I'm not going to get into that discussion, but she and the group, the University of Wisconsin Pain and Policy Group, came out with a manual on how to institutionalize, building an institutional commitment to pain. And multiple pediatric institutions started to do it as well. We did something similar at some of the hospitals that I was at, University of Wisconsin Children's, Steve Weissman. There were a number of other places that created pain initiatives which were institutionally based, which were sanctioned by the administration and came across and were felt to be a vital part of the care that they provided. How does one do that? Well, there's lots of different strategies, but Stevenson and June Dahl wrote a paper in the Journal of Pain and Symptom Management and basically said the cornerstone of that is having an interdisciplinary pain group, not the pain service, but a pain group that had administrative mandate to change. That assessment was critical, that there needed to be policies and procedures that specifically, within the institution, that specifically address this, that there was accountability, that pain information could be easily accessed to house staff, that there was even pain information available for families to know that they could then query their providers and say, I know that you're supposed to be providing better care because I've read about this. So those were all thought to be part of this. Educational things, an ongoing audit process were all part of this. And this is something that David Weissman developed as part of the University of Wisconsin. It's hard to read here, but this was one of their little sheets that they developed as sort of a checklist. Do they have all these different kinds of things in place? Flow sheets and assessment tools and patient satisfaction and new staff orientation, that pain was important. And again, for the nursing staff and as well as for all new hires as a part of their initiative. So then what I'm suggesting is that education is a piece of this, that guidelines are a piece of this, that quality improvement is a piece of this, but institutional commitment is the cornerstone of change, and that results in cultural change and ultimately in practice change. So that's easy to say, and I'm saying it, but it's not so easy necessarily to do. And the question is, how does one foster institutional commitments? And there's a carrot approach and a sort of stick approach. And we're all sort of familiar with the stick. Litigation, the JACO accreditation process, mandated education has now come about in many states in the US. There's even people who've talked about it being a human rights violation and basically a violation of the UN Convention on the Rights of the Child. Obviously, a family is not going to call the UN when their 4-year-old is getting inadequate post-operative pain management. So that's not a viable strategy, but it's the type of thing that people were thinking about. But the problem with the stick, and this is from Confucius, so this information's been around a while, if you use laws to direct people and punishments to control them, they will merely try to evade the punishments and will have no sense of shame. But if by virtue you guide them, and by rights you control them, there will be a sense of shame and a sense of right. And so that was sort of the basis of how people were thinking cultural change could come about. So those of us in the pain world started thinking about this a little bit at a time, and we're looking for models of how we could create a carrot that might be applicable. And the carrot we found was, or the model that we found was the baby-friendly initiatives. Were people familiar with baby-friendly for the most part? Anybody? Okay, a couple people. So baby-friendly is a combined project of the UN and of UNICEF. And it emerged when people, especially in developing countries, I don't know what the politically correct term for that is, but in low-income countries, were using formula instead of breastfeeding because it was thought to be the most scientific. Yet, in fact, as we all know, that was disastrous. They were using dirty water. People didn't have the money to afford the formula. They were diluting it up. Kids were getting inadequate calories. Turned out to be terrible. But in response to that, the UN and UNICEF developed this project where they would certify hospitals as what they call baby-friendly. And they had, if they met certain sorts of standards. And I'm not going to go through them all in detail because it's not as relevant, but basically they had a 10-step program that meant that you didn't give formula when the baby was leaving the hospital, that there were lactation consultants available, that there was a room available, that there was education available, and a variety of other, there was rooming in, a variety of other sorts of things that they felt and that were critical. And then they developed a process whereby institutions would self-appraise themselves to see whether they met those criteria or didn't meet those criteria. And after that, whether they if they met those criteria, they would have a site visit by some experts, usually associated with UNICEF or WHO in different countries, and they would then accredit them as baby-friendly, and that would have to happen every couple of years. So there are now 19,000 baby-friendly hospitals in 152 countries around the world. And lots and lots and lots of data that suggests it's had a significant impact on improving breastfeeding. So, some of us got the idea, duh, how about something like this, somewhat similar regarding pain management? And that's the sort of conceptual framework that we bring to this notion of Childkind that we're here today to discuss, at least in part. And that is the recognition that institutional commitment for sustained change is essential if we're going to change things, and that Baby-Friendly had this model of accrediting institutions, if you will, and providing some technical support for them. So suddenly a number of people came up with the notion that, that we could create an organization that would recognize institutions that did a good job in this, to give them a prestigious international approval that they were doing a good job, and that we would provide some of the technical support, if you will, to do that for them. And if they met those rigorous, relatively rigorous criteria, they would get this little logo that, that is over here, called that they were certified as Childkind hospitals. And that award, again, as I mentioned, would be independent of the level of institutional resource. In other words, it doesn't matter if you have easy access to ketamine or a number of other analgesic agents, but that the key was that you had a uniform approach, and this was viewed as important to you. And additionally, we felt it would be critical that Childkind would maintain a resource library that offered policies and protocols that were up to date so that institutions could have a template of which to use for their own institution, and it wouldn't, if they didn't have the expertise, it wouldn't preclude them becoming Childkind certified. Okay. So, again, I'm not going to belabor this. This is a picture of Bellagio, which we, through the generosity of the Mayday Fund and the Rockefeller Foundation, we gathered a group of folks from about 14 different countries, including the Baby-Friendly crew, to see if they could help us. And from that, we were endorsed, at least initially, by the SIG, special interest group of IASP in pediatric pain. They gave us the go-ahead. We organized this meeting. We had lots of folks there. And we developed a number of principles and an accreditation process. In those principles, I'm not going to belabor them. Bonnie's going to talk about them in detail, I would think. But they basically are that there's institutional commitment, that there's a comprehensive ongoing educational program in place, that there's adequate documentation that's evidence-informed of assessment, that there's evidence-informed protocols as well, and that there's an institutional self-monitoring program. So, over the years, we've acquired a number of endorsements from many other places. We've refined the accreditation process. Hey, teacher. Welcome back. We started piloting, and as you know, we're 4 initial hospitals in that group, and now that there are a couple of other wonderful additions with 6 more potentially in the pipeline, and hopefully many others of you here in the beginning of the pipeline. We hired a program director, Carrie, who's here. We started having a social media presence. And we started developing a relationship with Open Pediatrics, which, for those of you who don't know, is an amazing site, which is present in 150-something countries right now, and basically is a forum for discussion about pediatrics, mostly initially critical care, but now we're having a pain presence in there as well. These are the Childkind hospitals. And these are our endorsements from a lot of different places. As you can see, we're heavily Canadian focused because those are very kind and organized people. I'm not saying we're not, but they are. Again, I'm not going to talk too much about this, but why is this valuable? Again, we feel that it's a visible manifestation of the institution's commitment. It promotes pride in hospital staff, that their hospital is recognized for the humane care that it offers. It's evidence to consumers that the institution has made a commitment to improving the quality of the patient experience. Again, this is sort of stuff that actually this is the same thing twice. And it provides an organization a structured process to evaluate their current practices, allow an ability to benchmark against other institutions that are similar, and technical assistance to improve the quality of what they provide. And also, it provides links to like-minded individuals in a community, if you will. And that's a goal that we hope to foster. It's bringing together people who are interested in this, Childkind certified or not, but people who are interested in improving the quality of pain management and sharing information. And that's one of the things we hope to do in the Open Pediatrics site. So in the future, we hope to bring on a number of other people, a number of other Childkind hospitals, add international sites for the first time, and that's a discussion that we're going to be having about how to do that. In particular, we're going to expand the resource library that Carl is in charge of, which hopefully will have lots and lots and lots of protocols and policies and educational initiatives and videos and things that people can use, whether they're interested in Childkind or not interested in Childkind, to upgrade the quality of their pain care so they don't have to reinvent the wheel. Renee Mann-Warren has been working on a pain resource nurse group funded through another generous grant from the Mayday Fund, who's been an angel for all of us in pediatric pain. And that will be coming out, and we'll have the copyright for that so that it will be free distribution to everyone who's interested in that, to create sort of pain resource nurses. We want to develop a user group, as I've suggested, and Bruce Bernstein is here, and he has been working with us on thinking about instruments that we could use to measure the value of certification, the value of the process itself. Anne's going to be talking about that in a bit, about what thinking about pain management as a group can do for the institution. Again, this didn't happen in isolation. There have been wonderful, committed people who have been working very hard at doing this kind of work. We're all volunteers, basically. Nobody's getting reimbursed for this. Well, we're getting reimbursed for the food that we're bringing and for people's travel, but there's no reimbursement. People are just committed to this concept. The SIG, all of the presidents of the SIG, Gary previously, Carl now, I don't know who's coming up as president, but hopefully that individual will also have a strong commitment to this as being their baby, and will continue this work. So these are some of the names of some of the Childkind leadership. The advisory board is here, some of the folks. I hope there's no names I left out, but there might be, but if there are, I apologize. But basically this work has been done by this group of people, and we're so thankful. So in summary, we've made enormous progress in both research and clinical aspects of pediatric pain. The burden of pain that children suffer in hospital could be further enhanced if the current knowledge that we have is uniformly applied. Typical strategies such as education and guidelines and audits to change practice are more likely to be successful if they're part of an overall comprehensive institutional commitment to pain. And our initiative, the Childkind Initiative, encourages institutions to make such a commitment, helps them to do so, we hope, and recognizes them once they have. So that's all I have to say about sort of the history of Childkind and where we've come from. That's the conceptual framework that brought us here. And so any questions about that, about what we've been talking about? there'll be plenty of time for questions over time. We're hoping to get to know everybody over the next couple of days. Okay, thank you.